to record live stream. Oh, okay. Just 10-9-8-7-6-5-4-3-2-1. Good afternoon. This is Dr. John Bennett broadcasting from Miami Beach, home of Neurosurgical TV. We have the pleasure of having the Walter Dandy Yemen webcast, which has been probably the most active Walter Dandy presentation on the internet, and it's led by Ahmed Al-Ghanemi, very active, bringing great speakers to his webcast. And he's going to introduce the main speaker. Welcome, Ahmed.
Hi, John. Thank you for kind words. It's my pleasure and honor to have this webinar with you. First of all, here's Ahmed Al-Ghanemi, the president of Walter E. Dandy Neurosurgical Society, and also an executive administrator at the Walter E. Dandy Neurosurgical Society globally. Actually, I'm so pleased and delighted to have to get Professor Mehmet Zileli, who is the past president of the World Spinal Column Society and past president of the Turkish Neurosurgery Society. He is also the chair of the World Federation of Neurosurgical Society Education and Training Committee. So, hi, just Professor, can you hear me?
Yes. Yeah. Thank you, Ahmed, for very nice invitation. It's my great pleasure to be with you and to present that talk on the indication and techniques of occipitocervical fixation. Can I share my screen? Yeah.
Sure.
Yes. Now it is. Is it all right?
Yeah, perfect.
Good. Yeah. This is my talk, and before starting, I want to mention you a society which is not known very well. This is the Craniovertebral Junction and Spine Society. The chairman is Dr. Atul Goel, and there is one journal with the name of Journal of Craniovertebral Junction and Spine. I am the vice chairman of that society, and then we are trying to be active on the problems of the craniovertebral junction. As you may know, there are many problems of the junctional areas of the spine, and this unique junction of the craniocervical junction has also special problems. I will try to present my talk with this disorder and start with the problems of occipitocervical fixation. The question is there a problem? I believe yes, there is a problem, because we must tell that the unnecessary occipitocervical fixations are being done, and in many cases with C1, C2 instability only, have traditionally gone occiput C1, C2, even lower cervical spine fixations. However, this type of fixation significantly restrict head movements, especially the rotation of the head, and it has a high non-union rate. Yeah, the complications are quite high. If you look at the anatomy, the occipitoaxial joint is a very strong joint. The strength of the ligaments and the orientation of the joint surface provide remarkable stability. And in most of the cases, the unstable joint is not occipitoaxial joint, but the atlantoaxial joint. I come from the downward, actually. Probably this is about the complications we must mention. There are multiple complications of the occipitocervical fixation. One of them is the CSF fistula, because although you try to be in the middle, you can easily puncture the dura and cause some CSF fistula. Cerebellar hematoma may develop, and hardware-related complications like screw loosening, pseudoarthrosis, implant breakage are quite high. This is an old series from Dr. Vaccaro's series, 2010. He has mentioned that pseudoarthrosis and non-union is in 50% of the cases. It's quite common. We also published our 5-year mean follow-up results of 120 cases of occipitocervical fixation, and the indications were like this. Most of them were basal imagination, and we had complications in 26 patients. It was 52%. Implant-related, 32%, wound problems, 23%, systemic and other problems, and neurological complications. And we have to remove implants in 24% of the patients. And we concluded occipitocervical fixation has quite large number of complications and significantly restricts head movements. And we must limit our indications, and we must try to make shorter fixations as much as possible. In the literature, the non-union happens if you are using allografts, if the bone quality is low, especially in rheumatoid arthritis, diabetes, and smokers patients, severe deformities, if there are severe deformities, and hyperlordosis. This is a case of rod breakage after a while because of non-union. You see one rod is broken here. Back out of the screws is also common. This case had back out of the screws in the lateral masses, but it may also be in the occiput screws. So because of that, rigid forms of internal fixation has a significantly lower complication rates. This study from 2011 has shown that complication rate in non-rigid diffuse patients is about 48%. However, rigid diffuse patients is 10%. In those implant complications, we also found that if we have used all less rigid systems, the complications were quite higher than recent rigid systems. What about the technical evolution of occipitocervical fixation? We have started by using bone graft and cast many years before. Actually, we did not have that much of developed implants. Bone graft and cast we were using in 30 years before, probably. Bone graft and wires we then switched. Then we started using U-shaped rod and wires, plate and screws, Y-shaped plate and screws, and recently we are using small occipital plates and polyaxial screws in the upper cervical vertebra. I will give you some examples of the old-fashioned systems. These are historical implants now. Lucio-Hartschild rectangle was just a square-shaped rod or band rod, then fixating it with the wires. Then Hartschild-Ransford loops were specially designed for this purpose only. And somebody have used the acrylic bone cement with wires and loops and plates. I have done it in this child. He was 8 years old. I have done a C2 osteoblastoma surgery, anterior and posterior surgery. and we did a 2-axis plates, bent plate, and then multi-filament wires between the boreholes. Then this case is from 1996. We used to do buzzer imagination cases, a transroll odontoid resection and a posterior fixation, and with laminar clamps and U-shaped occipital plate. We then used 2 plates, then Y plate. Y plate is better because in the middle of the occipital bone, the thickness of the bone is better than the lateral parts. This is some examples of the Y plate. The screw purchase is more stable in the middle of the occiput. Then we switch from U-shaped plate to Y-shaped plate, and this is a case from 1997. Again, a buzzer imagination with Chiari malformation. We have done a first transroll resection, then a posterior decompression of the tonsillar herniation, and a posterior occipitocervical fixation. This was a long fixation, in fact, which we don't like it now. Currently, we don't use it. Then the era started with the more rigid fixation techniques like the polyaxial screws and some occipital screws. And there are multiple systems in the market, like this one, a plate and hook in one side, or an occipital plate in the middle, and then 2 plates are connected with that occipital plate. This is the intraoperative films of that system. In 2004, we started to make posterior fixations, like you see. Sorry, this was an odontoid resection again with a long fixation in the occipitocervical area. We then published our series in 2002, a combined anterior and posterior approach for managing buzzer imagination in one stage. However, Dr. Goel has developed his own technique, first fixation techniques for C1 lateral mass, then treatment of buzzer imagination by a posterior surgery. It was that paper, 2004, revolutionized the buzzer imagination treatment. And that Goel technique has been popularized by Dr. Harms, and he has then named, some surgeons has named it Harms technique, but it is better to call it Goel Harms technique. There is a lower risk of injury to the vertebral artery, and C2 pedicle screw may have some risks. With 25-degree medial and rostral angulation, you can easily place it in the proper place. If you want to go downward, you can then use lateral mass screws, and even you can use also subaxial pedicle screws. This is typical Goel Harms C1, C2 fixation for such a case with buzzer imagination and atlantoaxial dislocation. So after Goel's introduction of the reduction technique by placing a spacer inside the atlantoaxial joint and pulling down the buzzer tip, odontoid tip downward, you can reduce the buzzer imagination. This is the cases of I have done after learning this technique. This is direct X-rays. There is some dislocation atlantoaxial dislocation in flexion, and you can see easily there is an atlas assimilation, C1 assimilation. In this case, we then had done an occipitocervical fixation with some decompression in the foramen magnum, and placing a good spacer on one side, and this is postoperative films of the same patient. It's another case, 2009, with C1, C2 dislocation. We have done a very short fixation, C1 and C2 only. Did not include occiput to that fixation. In case of atlas assimilation, you can still make a C1, C2 fixation or occiput to C2 fixation. These are films of that patient, preoperative and postoperative. So if we look at the historical evolvement of the occipitocervical fixation, we used to do some hook devices. Then we switched to use plate, specially designed plates with lateral mass screws. And then we switched to polyaxial screws, and we started doing shorter fixations by the time. So we used to do long fixations, applications to all craniocervical pathologies without reduction. We then now came to shorter fixation, separate indications, and reduction could mostly be achieved. What are the indications of occipitocervical fixations? Absolute indication is traumatic occipitoatlantal instability. It is quite uncommon trauma. It's very rare, and it, as you know, many cases have fatal outcomes. They die mostly. Occipitoatlantal instability due to basal imagination, in case there is an irreducibility, in case there is atlas assimilation, dyskinesis of the C1 lateral mass and occipital condyles, and you can make occipito to atlas fixations. Tumors and infections invading occipitoatlantal joint and rheumatoid basal imaginations may need also occipitocervical fixation. Relative indications are odontoid rejections, Down syndrome, and cranial settling, cases with osteoporosis because you need to have more fixation points, irreducible rheumatoid dislocations, complex C1, C2 fracture dislocation, and revision cases. If you look at the upper cervical instability in case of trauma, then we must first ask where is the instability? Is it occipitoatlantal or atlantoaxial? If it is atlantoaxial only, and if it is reducible, just C1, C2 fusion is okay. If it is irreducible, you need to make an anterior decompression and plus posterior fusion. But if there is occipitoatlantal instability, then you can consider an occiput, adding the occiput to your fixation. In non-trauma, it is similar. But if there is neural compression and myelopathy, if there is no myelopathy, then you can just follow up. In case there is no myelopathy, I'm still following up the basal imagination cases. However, if there is instability, then you have the similar algorithm. For technical considerations, actually, I don't want to give more details, but prone position, neck must be neutral. Lateral C-arm control is okay. Mayfield head holder, I prefer this, but some other surgeons prefer a traction device during surgery. reduction with traction may be done by this traction device or by loosening the Mayfield head holder and applying some manual traction and fixation the Mayfield head holder again. Preoperative, you must measure the thickness of occipital bone, and you must look at the vertebral artery anomalies in the C1 and C2. Bone graft should be placed between occipital and cervical vertebra. I always prefer an autograft in those cases. I never use allograft. How much we must go downward? We need a case-based evaluation. Ideal is C0, C2, or C3. But as I mentioned before, rheumatoid arthritis cases, tumor cases, and hyperlordotic cases should better go longer downward fixations. If you cannot reduce it, then you need to make a odontoid resection. If there is a C1 assimilation, it is your choice. You can make a assimilated C1 puncture and screwing, or an occiput screwing. It's your choice. In conclusions, in the last 20 years, we had two great refinements. Posterior reduction of posterior invagination is possible. C1, C2 screw fixation techniques has developed. There are also alternatives I did not mention here, like placing screws on the C1 lamina and C1, C2, C2 lamina and C2 pars region. Occipitocervical fixation restricts head movements and has a very high non-union rate. And the main problem is the decision for whether an occiput C1 or C1, C2 instability present. Most cases have only C1, C2 instability, and occiput cervical fixation is unnecessary. And shorter fixation must be tried as much as possible. And reducible basilar invagination, some author says there is no unreducible cases, but inability to reduce is a problem, especially in the less experienced hands. So then you can still consider some anterior decompressions. So I want to finish my talk here, and I want to promote to come to September 27, 29 WFNS educational course and the Tunisia Middle East Spine Congress in Monastir city of Tunisia. Thank you for listening to me.
Okay, Ahmed?
Thank you, Professor Ahmed. It was a very fantastic and informative lecture. For that, I hope to invite Your Excellency again and again for our coming webinars in the coming few weeks. Also, it's our pleasure and honor to show you or offer Your Excellency to have a collaboration with the WFNS Education and Training Committee soon, inshallah.
Thank you. Thank you a lot. It's my pleasure.
Good evening, everyone.
Review.
Yeah, hello. First, I'd like to apologize. I have a problem with my connection here. I'm in Argentina now, in a countryside, in the area that the connection for the my computer is not working. I don't know, I cannot present today. But I was listening, I watched the presentation of Mehmet. Brilliant and very, very clear. We see several times. I want to say some words about tumor of the cranioceptional junction, that the one that Mehmet didn't talk about. The most common tumor in the craniocephaly junction is the meningioma. They call foramen magnum meningioma. And foramen magnum has more approach than real cases. Everyone invents one approach, another approach. And the relation, the question that is coming to everyone is about the fixation. If you need, you don't need fixate. And the amount of condyle that you remove. The majority of the time of the intradural tumor, as meningioma, the amount of condyle that you remove is minimal, sometimes nothing. In certain occasions, you need to remove a little bit more. But does not mean that you need to remove, you need to do a fixation for meningioma. It's different for chordomas, it's different for other kind of bone tumor. And in this case, that you have more removal of the bone, especially the condyle and the lower part of the clivus, maybe you need fixation. In 1995, I was in Little Rock in Arkansas. We published a study to approach the odontoid, especially for our rheumatoid arthritis, through the lateral approach, through the transcondylar approach. It was 12 decades. We did unilateral fixation. See? Do you know what's happened? In 12 cases, 8 cases had to come back to do a bilateral fixation. Do you know why? The craniocervical area, craniocervical joint, are extremely mobile. See?
Yeah.
We move the neck more than 800 times per minute. See?
Exactly.
Try to
Yes.
hold the head.
Mm.
This is the biggest problem that you have in this area, in the high level of fusion. I remember that Professor Menezes, during many, many years, he has a lot of Arnold Menezes. He was doing the craniocervical fixation, occipital C1, C2, sometimes C3, but they put the patient in the halo for 3 or 6 months. Everyone will work.
Yeah.
I think the failure of this large fixation, long fixation, is a little bit higher in the craniocephaly junction than in other area. What do you think, Mehmet, about that?
Yeah, completely right. First of all, I don't think it's necessary to make any fixation in foramen magnum meningioma surgery because you don't remove the joint, just probably
Just
yes,
a little bit or
just
nothing.
yeah, or nothing. And unilateral fixation, although I heard it from many surgeons, but I didn't do it in any case. But in my series, sometimes I have to remove later, after 1.5 or 2 years, I have to remove the occipitocervical fixation because it restricts too much movements, and sometimes in a late period, it causes some overstress in the lower cervical spine if you are lengthening the downward. I'm for making bilateral fixations if there is a iatrogenic instability, especially in chordoma patients. Because chordoma is distracting the bone itself. There is no other way.
Yeah.
Thank you.
Yeah, excellent. Yeah, and this short fixation that Boyle saying try to popularize among the world, do you think less is more? Shorter is better than longer fixation in this area? I think so, no? What do you think?
Yeah, actually, it depends on the indications. If it is a basal immigration, shorter fixation is justified. However, if it is odontoid, os odontoideum, it's very unstable, too much unstable. I have a few cases who has, with short fixations, who has screw breakage. So I was frustrated by having, by seeing those. So probably some people are not reporting their complication rates nicely. As I mentioned, there are more than 50% complication rate of occipitocervical fixations. Quite high, very
Yeah.
high.
And there are a lot of there is a lot of bone abnormalities also.
Exactly.
You
Yes.
cannot put in the correct position. It's not the real. If you see
Yeah.
a normal guy, if his anatomy is very clear, it's one kind of thing. But the patient's disease, sometimes the condyle is very small, the lateral mass is very small, the vertebral is going around. It's more
Yeah.
difficult to have a really, really nice fixation. I think. Very, very, very
Yes.
interesting.
Exactly.
Another question to you. Do you believe that the transoral approach is that we still have a role to the transoral approach? Especially for the
Re-
patient who have a severe complication, sometimes myelopathy, they had tetraparesis more than cerebral symptoms. See, what do you think the transoral is by endoscope or by microscope or any kind of approach? You think you still have a role to the transoral approach?
Yeah, actually, there are alternatives to transoral, as you know, like transnasal endoscopic decompression. It's a viable option. It's okay. But indications of ventral decompressions are quite lower now. There are a few cases that you cannot reduce in basilar imagination. And if there is a tumor invading the C1 and C2, and you don't have much options. You must have an anterior surgery, especially in tumors.
And yes, and posterior fixation later. No?
Yeah, it is necessary to
Yeah.
make a posterior fixation because
You do
anterior
in the
fixation
same
is not easy. I have done a few
Yeah.
cases of clivus to C2, C3 fixations, but it's very
Yeah, but-
big surgery, and even with transoral surgery you
and
cannot
fail a
manage
lot.
it. Yeah,
Yeah, and fail a lot. Infections is more difficult to
right.
control also in the anterior part. Yeah. Excellent. I see there is some question here. So if Ahmed want to address.
Yeah,
I'm
Amanda.
very sorry
Zoran,
again.
yeah, Zoran Matute is a neurosurgeon from Hermosillo, Mexico, a spine surgeon, asked, what is your fixation method in C2 on a patient with high riding vertebral artery?
Yeah, I see that. I see the question. Yeah, in that case, there are two options. One is the C2 laminar fixation, which I use mostly. This is my preference. The other one is the pars screw of the C2. But in case there is a high riding artery, I use laminar screws. There is no
Okay,
other
Ahmed?
question.
Ahmed? Hey, Ahmed, it's all yours.
Did you hear me?
Yes, any more questions,
Yeah.
Ahmed?
Okay.
Yeah, any more questions, Ahmed?
Depends.
What are we gonna do here?
Yeah. I mean,
Here, well,
just a minute to check the chat. Okay, I think there is no much more questions, but
Yes. You got most of the questions. Yeah, I think you got them all.
hi. Well, I will just. Can you hear me, John?
Yes,
Hello.
yes, we can hear you.
I will.
Okay, Amanda, are we losing you there?
Thank you.